Good afternoon, Parliament speakers, distinguished guests, colleagues, students, and friends. On behalf of the school, I welcome you all to the book launch seminar, Strategic Investment for Health System Resilience, a three-layer framework. We are happy and honored to have two of the book authors, Dr. Feng Zhao and Professor David Bishai, here with us today. We would also like to take this opportunity to give our heartfelt appreciation to our co-sponsor, represented by Professor Inuk Hwang, Deputy Director of Primary Healthcare Academy, the University of Hong Kong, and our supporting partner, the Hong Kong Jockey Club Global Health Institute, represented by Professor Herding Young. Without further ado, let me invite Professor Inuk Hwang, Deputy Director of our co-sponsor, Primary Healthcare Academy, Hong Kong U, to give the welcome remark. Professor Wang, please.
So good afternoon. Thank you so much for coming. Thank you for the introductions. So it is really my great pleasure and also honor to welcome all of you to this book launch on the strategic investment for the health system resilience, a three layers framework written by Dr. Feng Zhao and also Professor David Bishai, and organized by the School of Public Health. I'm Kelvin, as introduced. I'm the Deputy Director of the Primary Healthcare Academy at Hong Kong U. And I would also like to warm welcome everyone to join this seminar, and also the distinguished guests for your attendance. So your presence today is really greatly appreciated and will be adding the excitement and all the significance for this event. So I'll give a little bit of introduction of Dr. Zhao, long CV, but I just try my best to highlight those important things. So Dr. Zhao has more than 30 years of experience in public health, medicine, economics, and demography at global, regional, and country level. He has extensively worked on the health policy dialogues, technical work, and also operation, particularly in Africa, Europe, and Central Asia. So at present, he manages World Bank's health programs in many areas, including in South Asia. And Dr. Zhao has plays a very important role in the developing strategy and flagship initiative to address critical health issues worldwide. For example, spearhead the WHO's emergency response efforts and design the global COVID multi-phasing program, and manage health programs in diverse settings. Previously, Dr. Zhao held various positions at the World Bank, and he demonstrated a multidisciplinary approach to tackle the healthcare challenges and also the strategic leadership in shaping the health policy initiative in various regions. So I also introduce another author, Professor Bishai, who we know very, very well. And Bishai is the clinical professor in public health and also the director of the School of Public Health at Hong Kong U. So before joining the Hong Kong U, Professor Bishai was the professor at the Johns Hopkins Bloomberg School of Public Health for 27 years, and also served as a local health officer in Maryland Department of Health in 2021. He is a distinguished leader in the public health with a background in both academia and also the government sector. So as a leading health economist, his research focuses on effectiveness and funding global public health activities, primary health care, vaccines, and health disparities. He has written 2 books and has published more than 260 peer-reviewed scientific publications. His award-winning courses on the system thinking and also the health economics have reached over 40,000 students. So in his role as the president of the International Health Economics Association, he contributes to establish a global mentoring program network for early career researchers. So this book, The Strategic Investment for Health System Resilience, a three-layer framework, presents a very comprehensive investment framework designed to enhance the health system's resilience in the face of emergency. So the framework consists of 3 layers, right, as written, the risk reduction through the primary health care and prevention, the detections and containment capability, and also the advanced case management and the surge response. So by prioritizing all this by prioritizing all these interventions, the book emphasized the importance of well-run approach to public health, so that can respond to the both fasting epidemic and also the long-term non-communicable disease trend. So this were offering a very cost-effective strategies for the lower and also the middle-income countries. So we hope this work can act as very significant resources for our researchers here and also in the world, while also connecting our policymakers in Hong Kong and also in different places with the healthcare professional to enhance the access to the quality care and foster, most importantly, health equity. So I would like to express again my gratitude to all of you to presence for your support, and also your presence enthusiastic will make this celebration truly memorable. And we also look forward to the active discussion and also the new avenue for this for the research this book may bring. So once again, thank you so much.
Thank you, Dr. Zhao. May I now invite Dr. Feng Zhao, Practice Manager, Health, Nutrition and Population, South Asia Region, the World Bank. Dr. Zhao will share valuable insight about the book with us today. Dr. Zhao, please.
Okay. Good afternoon. Very, very happy to be here. I've been to Hong Kong many times, but this is the first time come here with a book launching event. Really looking forward to it. This is actually the very first book launch for this book globally. Just months ago, we at the World Bank annual meeting, we featured this book, but didn't really have a seminar like this one. So we're lucky as the authors to have a designated seminar for this. If I may, you're also lucky to be part of the first one to enjoy the substance. Let me just say, we plan to launch this book also in a series of events, mainly also tag on our policy dialogue at regional and country level. We have a few events already being planned. One of the follow-up activity after this one will be a side meeting at the PMAC. I don't know how many of you knows PMAC, the Prince Mahidol Award Conference, which is a major global conference which will take place in January. So we have planned a side meeting, and also at the country level we have agreed with different countries, particularly my responsible countries, to have used this book as a policy dialogue tool to help and design their pandemic and One Health strategy. So just to give you some ideas. One insight I can share with you, I mentioned the World Bank annual meeting last month, October. World Bank and IMF have two annual events every year, the spring meeting and annual meeting. The annual meeting normally takes place in October. This is where all the finance ministers across the world gathered in Washington, D.C., and also the central bank governors. The World Bank Knowledge Shop, which is basically our bookstore, have a big desk in our atrium, in our lobby, and this book was right in the middle. I have a few photos I took. They're selling it for $40 per copy, and also they're selling it on Amazon. But we have few free copies. Professor David Bishai has prepared, so you can take some free copies. And also there, this is a secret. If you go to the World Bank website, you type OKR World Bank and the title of the book, you got a free PDF file. So you can just try that. You can have a download. So let me start off by saying This event took some time to materialize. It's mainly my fault. We started planning this event in August, but something happened in Bangladesh. You probably have learned, and some emergency I have to handle. So it postponed until now. But I'm happy. Eventually, it's happening. I'm very happy to share the stories behind this book. I have only 15 minutes. I want to mix some storytelling with some of the substance because every book there's a story behind it. I want to share with you some of the background, why we wrote this book, why now, who are the audience, where we started. And also I will dive into the framework of the book. Mainly it's a 3-layer framework. It's already on the title. And also maybe some messages I can share with you since we have many students here. What's the take-home message for you to digest and think about it after this seminar? So let me start by saying, since we're talking about stories, and I also want to mix my previous experience, and also this is where the book started. What do you think is the most difficult relation to manage in-house? I can tell you it's not between US and China, it's not between WHO and the World Bank. That's my view. Any guess? We can make it a bit informal and interactive. Yeah. Okay, so my view is really between Ministry of Finance and Ministry of Health at country level, because that conversation is so difficult. I have not seen one single country who manage it perfectly. There's always difficulties in terms of the language they speak, in terms of the common vision they see, in terms of the understanding they have, right? So health is complex. I'm sure in your course you have learned this two production function of health, and also different vertical systems, which make health probably the most complex sector for Ministry of Finance colleagues to understand. At the same time, most of us are trained in medicine or public health. We really didn't have the financial management, the budgeting management skills. It's hard for us to understand, the language they speak. In my earlier time, one thing I did, which I'm proud, is working with Harvard University. We put together a training program just for Minister of Finance, nothing else. So we have 30, 40 Minister of Finance gathered in Boston. We took away their mobile phones and make sure they concentrate. For 4 days, talk about how they strategize health, how they dealing with colleagues in their health sector, how do they manage different priorities. But what I learned, I interviewed every single one of them. One thing I learned from them is they're scared of health, because one minister told me, one of the health minister told him, he's the finance minister, basically during a cabinet meeting, just say, what do you know health? You're not doctor, right? So that's one, insight he shared. I also learned that the world shortest conversation is between Minister of Finance and Minister of Health. The story being in the cabinet, Prime Minister's compound, and the Health Minister saw the Finance Minister, really eager to have a conversation and just say hi. And the Minister of Finance saw the Minister of Health, just say bye. That's it. So that highlight the difficulty there. But the World Bank, our main clients in different countries, Ministry of Finance. So we agree with our overall financing and plan with Ministry of Finance. And then from there, we work with different sectors. right? So I'm health, I work with Ministry of Health quite a bit, but Ministry of Finance is our main counterpart. During COVID, when I was leading the World Bank's COVID emergency program, one thing I found is really Ministry of Finance colleagues, they know, okay, COVID, we have to really put our resource in and we're handling this emergency. But when they talk to our health community, it's just all sort of priority popped up, making them very difficult to concentrate on the priorities. So I'm thinking, can we come up with a simple framework to help Ministry of Finance to understand when they make an investment decision. By the way, the investment decision is largely made by Ministry of Finance, not Ministry of Health. So we need to engage them. We need to communicate with them. We need to educate them and being educated at the same time. So COVID is really a great learning opportunity for all of us, because normally when Ministry of Finance saw the emergency, this is the time they want to step in big time. But if in peacetime, if you want to talk to them saying, let's invest in primary health care, in prevention preparedness, normally you don't get very strong response. So we don't want to waste every pandemic, right? As we said, we want to really use it as an opportunity to touch on that. So that's the thinking behind it. The simple framework will come in play. So, okay, I need to do this. So just to let you know, this book is not a single book on itself. It's actually a series of knowledge product we have been thinking at the World Bank. Even during COVID, the framework book we published is how primary health care system need to evolve. How do we reimagine primary health system? We actually come up with a call for global community for 4 transformations for primary health care. Because the primary health care of the old time, it just simply cannot adopt the current situation, and they are not even relevant. For example, primary health care was always seen as the low quality care, right? You only go there with simple disease treatment, and then whenever you need good quality care, you go to higher level. And there's a lot of things like NCD mental health was not part of the primary health care system design in the current situation. How do we integrate it and make it people-centered? How do we also ensure fairness and accountability, have a community-driven approach? And lastly, is relevant to this book, is how do we make sure they have the resilience element into it, so the pandemic preparedness is part of primary health care. So with this framework, we have a few deep dive product. One is the World Bank flagship report, Change Cannot Wait. It's published a few years ago. You can get the PDF file if you search it. And in there, we actually introduced this 3-layer framework to guide particular Ministry of Finance to think through the investment priority. The framework, the 3-layer framework was mentioned in this product, but also was as a single paper is published at BMJ, British Medical Journal. And we also have other deep dive product. For example, we also recently published the Silver Opportunity book, which is how to integrate aging and elderly care into primary health care. So that's another deep dive. Now come to this book. This is one of the products we really want to integrate PPR, One Health pandemic preparedness into primary health care. This is original thinking, but we end up developed a comprehensive 3-layer framework. You have seen this, I don't want to dive deep into it, but basically we see when you go through the investment thinking, you need to think about the 3 layers, right? So layer one is really, okay, how do I go back? Layer one is we can call it upstream layer, which you can invest in peacetime, but really think about prevention and preparedness. You want to prevent potential health outbreak, endemic, pandemic, or outbreak from the early phase. That's the most effective, most efficient investment. And then when we have early phase outbreak, you use the key public health functions and to make sure we have the layer 2 in place. And lastly, when you get to a full-blown pandemic, you have to have the surgical capacity, you have to save lives. At this point, price tag is out of window, whatever the cost you give in. So that should be the systematic sequence. But what we see COVID is the reverse of it, right? What do you see on TV during COVID? It's all about hospital, emergency room, ventilators, vaccines, materials, this and that. It's all about the last layer, right? So this is the perception we want to reverse. Of course, in that phase is much needed, but you have missed a lot of cost-effective interventions in the early phase. So that's the whole point of it. So the book has 2 parts. The first part is really talk about this framework and about the 3 layers, so you can look into it. And then Dr. Bishai and others did a very in-depth study on the current resources spent on each layer. So that's really elevated the whole book because we have the spending and the allocation and the efficiency angle to come into this. And then we have part 2, which we brought in a set of country cases, and they all approached this 3 layer from different angles. Some country focus on first layer, some countries really strengthen the public health function as second layer, and some countries really have some innovation in the 3rd layer. So later on, after Professor Bishai, we'll have Dr. Inuk, which is connected. We'll talk about the experience of Korea. Korea has been one country which has a lot of innovation emerged from COVID. So we're looking forward to listen to that. Just want to acknowledge this product also is a partnership with Gates Venture. You probably know about the Global Exemplar Program, which they identify outliers, mostly positive outliers in different areas. So they have some of their case study as part of this chapter. Okay, I already mentioned the 3 layers, so they each focus on different things. But I want to really focus on this slide. Is the 3 layers, they interact with each other. During the review of the book, I received a lot of comments basically saying, okay, you're criticizing layer 3, but it's much needed. What do we do? So my point is all 3 layers, they function differently, but they also interact with each other. There's also a time sequence you can look into. First, think about prevention and preparedness, but they also enable fast response in later layers. The key public health function, early detection, containment, also enhance system readiness. And also for the last layer is rely on the early layer for sustainability. No country can afford a pandemic like COVID repeatedly, right? The global spending for pandemic is over 17 trillion, and the overall regular time health expenditure is just about 9 trillion. So how many times we can have these resources for a pandemic like this? Now let's go to my last slide, because this is in a university. I want to share some thoughts, particularly with our students. By the way, 25 years ago, I graduated from Hopkins. My thesis advisor is by the name of Professor David Bishai, just to share with you. First, the health resilience agenda is a global agenda. So regardless where you are, what you study, even you have interest in only one country, the global is increasingly connected. So for students, even you're working on one country, you want to become expert of Hong Kong, China, or whatever, you have to know what's happening globally. So that's one thing. Just use this layer, learn different case studies will be beneficial. The second is the health system is very complex. You need to use different approach to study it or to work on it. This multi-layer approach, which walk you through the different investment strategy and different research strategy. There's a lot of angle can come into it in terms of cost efficiency, in terms of prevention versus treatment, in terms of public health function versus integrated primary health care. So looking into it will help you. And also there's practical applications of public health theory. You have this global framework of the three-layer framework, but you will see how different countries adapt to it. They all use different approach. There's no cookie cutter, no one-size-fits-all. So just study different cases will help you understand global health. And there's a strong cost-effective resource allocation, and Professor David will talk more. And lastly, if you think about the career in global health, you have to understand all those dynamics. When you go to an interview, you cannot only talk about one aspect or one country experience, and try to broaden your view and learn and catch up literature in different settings. I'm running out of time. I'm probably over time, but happy to answer any questions. Thank you so much.
Thank you, Dr. Zhao. So thank you for your introduction for the book. Now may we invite Professor David Bishai, the Director and Clinical Professor of the School of Public Health Hong Kong U. Professor Bishai will dive deeper into the chapters 2 and 3 of the book on implementation pathway and courses. Professor Bishai, please.
Thank you so much. Thank you, Feng, for your introduction and for the opportunity to participate in the book. Let me dive into chapters 2 and 3 on what we wanted to share with ministers of finance, ministers of health. The main points is that there's an immediate dividend. This is not an investment where you have to wait a decade to start benefiting. You don't have to wait for the next pandemic. The other part is you're not building a brand new thing. You don't have to create a brand new resilience agency. The resilience workforce is already here. It's called the local public health department, and you have them everywhere. The question is, how can we build a pathway so that these health departments can do their job? How can they be more effective? Their job has been established, and it's called the essential public health functions. And for us in the schools of public health, we want to make sure that we can train the workforce in these essential public health functions. The middle bullet is that when we talk about a strategy for resilience, there is a one-to-one mapping of essential public health functions and the things you have to do to be resilient. So the pathway forward is to improve the essential public health functions using a checklist to measure the health department's capacity and to enlist the health departments in improving their work using a checklist. The final thing I'll mention is this idea of the resilience centurion, shepherding the health department to do the work of improving resilience. So 3 pieces of my very brief talk. What is resilience and why do we care? What do we want to do to implement, and what are the resources? So first off, just for those of you who want to go back to definitions of resilience, this goes back to the Rockefeller Foundation definition of resilience written up by Margaret Crook from Harvard. 5 elements of resilience. A resilient system is aware, it knows what's going on in its environment, it is diverse, it has multiple components that self-regulate and integrate. They work together harmoniously, and it adapts to the problems that are coming. Why invest? Well, you want to prepare for a crisis. There's another pandemic. There's also a crisis right now. There's polycrisis in our world right now. We want to be good at handling them. There's a need for ongoing climate resilience now. We've all lived through this summer. We've lived through some of the hottest months Hong Kong has ever had. Around the world, people are having their hottest months. Heat waves happen to be the most lethal weather events. Even when we have a typhoon warning, we're at a 3 today. Typhoons don't kill as many people in Hong Kong as heat waves. Around the world, rain and floods are not the biggest killer, and we have to be resilient against this issue going forward. Back to my one-to-one mapping, this is throughout the book. Monitoring health status is an essential public health function. As I said, resilience is being aware of risks. Diagnosing and investigating health hazards is an essential public health function. Epidemiological surveillance is in the resilience index. On and on. What we want in resilience, we get if we work on essential public health functions. How do we implement? How do we get this? Resilience always seems so, idealized. Is there a pathway? And there is. It's wrong to think that the only thing to do is to stockpile supplies and people, that we have this reserve army of people that we have to have ready. That's very expensive. It's not wrong, but it's a pretty expensive way to be resilient. More important is to have our current public health workforce be aware, self-regulating, and adaptive. You needed to do that anyway. If you're paying public health workers to be around, you want them to be good at their job. So the pathway is to start with measurement, to be aware of our capability, awareness of our assets and our needs. We want our public health workforce to be connected to the community. So part of your job as a health officer is to be out there with the schools and with NGOs, with the private sector, building those connections now and building a workforce that knows it has to connect. You have to show up to make these connections. And then once you've shown up, to co-create and integrate, bring them into the planning process of the things you're doing for the community right now. And then finally, self-regulate. Use the data to make the changes and keep going through that cycle. This is the cycle that all students of public health should memorize. If you want a tattoo, this would be a great tattoo for any of you wanting to go and get something, because if you go into public health, this is you. This is what you do. You assess, you develop policies, and you assure solutions to policies. These are all 10 essential public health functions. We've gone through some of them, but they do break out into the 3 parts of that tattoo: assessment, developing policy, and assurance, which you can see written sideways here. But all of our essential public health functions are the pathway to resilience. We have 20 years of building measurement tools for these essential public health functions. There are many, many checklists that are waiting to be used all around the world. Countries have had their national public health institutes endorse them. These stress all of the elements of resilience and the strategy of using audit and feedback. Check your capability, give feedback to the health workers so that they can produce a quality improvement plan. This is just a QR code that links you to a repository, thanks to Tom IT. Thank you, Tom, for putting together this compendium of these multiple checklists for measuring essential public health functions. So audit and feedback. You go to a county health department or a CDC, you motivate a concern for quality improvement and coaching, you measure the current skills. You don't use this as a whip to punish, you use it as a guide to performance improvement. The status quo has been top down, where we measure resilience and then dictate what to do. Better to do a bottom up, where we assess the frontline worker and give them the motivation and the skills they need at the front lines of the public health, at the very bottom of this 3-layer framework. So here is an example of what you would get with a checklist. These are bars measuring basically a report card of a frontline public health unit. You give the report card to that frontline unit, you give them a coach, they get phone follow-up, and they'll get resources to help them do their job better. This is like any business would do. If you were a competitive business anywhere in the world, you're wanting to make your products better every day, and you're doing something that looks a lot like this. Culture of intrinsically motivating high quality. What is it going to take to implement this pathway? How do we do it? Well, there's a roadmap that starts with a high-level commitment to doing this. You need a chief executive or a program leader that wants it to happen. Then you need an embedded team inside that front line that is measuring resilience and coaching. They will have a consensus that that's what they want to do, that they want to be more resilient. And then they'll go through these perpetual cycles of resilience, measurement, feedback, and planning. Now, the funding. Of course there's going to be some resources involved. But one of our messages is, this is not building something from scratch. There are 3 layers. This bottom layer matters a lot, but it integrates. If you're good at layer 1, you're going to be good at these other 3 layers. Those essential public health functions are actually helping to manage layer 2 and layer 3. So the public health mission is to make sure that the entire edifice of the 3 layers is resilient. So the thing about layer 1, it's the lowest cost. If you want to invest, it's the most neglected, as public health is invisible. It prevents, it doesn't cure often, and so governments seem to neglect it. But what would it cost if we wanted to pay attention? So in chapter 3, we started looking at the spending on these multiple layers. And so this is essentially at layer 1 in low-income countries costing $2 per capita per year. The second layer costing $9 per capita per year in low-income countries, and the top layer costing $27 per capita per year. So if you do the math, you'd see that the bottom layer is only 5% of the total of 2 plus 9 plus 24. Only 5% of your health budget in a low-income country needs to be spent on layer 1. We are not asking for brand new hospitals and intensive care units. We're asking for these frontline public health workers. They don't cost a lot. The other thing is they're already there. So you don't actually need new money for the front line. What you need is this system that we talked about, the investment in their capability and their functions. So that's even less than 5%. It's 1/100th of 5%. The centurion is this idea that the Roman army had, where you would have one centurion, a commander of a legion of 100 fighting Roman soldiers. So the 1:100 ratio is a really decent supervisory capacity. Some of our courses here, we have one principal lecturer for 100 students. So you can get by doing a lot of capability with a 1:100 ratio. The centurion would know capability, and they would work with their phalanx of soldiers to be better. But they only need 1% in order to be devoted to this job. So 1/100th of 5% is half a cent. And I tried to take a picture of a half a cent. That's the investment that would start you on this journey towards resilient, paying for the centurions who are working in this public health workforce. Last ideas of how you would spur action. One thing is to write a book, but more is a demonstration project, several pilot studies where we would invest in the centurions and show what's going to happen. We're investing so much in so many bits of science and technology. We've got lots of moon landings, lots of trials for drugs and cancer and diabetes. We actually have not done a prospective trial of a resilience intervention such as a centurion intervention, and it wouldn't take much to demonstrate that this type of intervention of investing in the quality of public health would pay dividends right away in improving all the things you care about: better surveillance, better vaccine coverage, better screening for cancer, and on and on. So one would take 10 intervention counties, do the centurion intervention, take 10 control counties, and then see what would happen to their performance in health risk behaviors and outcomes. I'm going to make the safe prediction that the intervention counties would make more use of community resources. They would activate volunteers and NGOs. They would activate people that are not in the health sector and add them to the resilience army. So you would get more people working towards preparedness and for public health with this design. So in future directions, we would incentivize our workforce to work in this area. We would start to find a good place for the trial. Let's find a province with a high-level commitment to future resilience, a provincial CDC staff that wants to use these tools, and an openness to prospective evaluation. So my team at Hong Kong U is eager to work either in Hong Kong or perhaps somewhere in mainland China where there is this commitment to having a very high quality public service. When I travel to mainland China, I see pictures like this everywhere to try to incentivize high quality all over. And why not put these smiley faces right over our public health department, so we would incentivize them as well. So quality improvement is something important. In clinical medicine, 30 years ago, this document came out from the Institute of Medicine. The quote was, between the healthcare that we have and the healthcare that we could have lies a chasm. And that's really still true in public health practice. We have a chasm. And even though the Institute of Medicine has started closing that gap, and it's closing it with what looks to me like quality assurance units. Hospitals around the world have safety officers and quality officers. We want to take a page out of this book and say, let's do quality officers in public health practice. So we already have the Army. We already have these public health departments. There are 60,000 local health departments on the planet. We just need to pay a half a penny for the centurions. Here's our centurion over on the right, who is going to help this fighting force be ready for the next pandemic. So in summary, resilience requires a public health workforce that can sense and think and act. The curriculum they have is the curriculum that we have, the essential public health functions. And we just want to invest in returning to our roots in public health. We want our local health departments to measure and coach essential public health functions to set off this chain reaction. And that would be the catalyst that would set off our reaction. We want to generate local evidence, and I'm ready to work on that agenda. So thanks for coming, and now we'll try to tune in to our next guest from Korea.
Thank you, Professor Bishai. So, as spoken, today we have Dr. Inuk Hwang, Research Fellow at Seoul Institute and Graduate School of Public Health, to come with us to have this case study on the topic from MERS to COVID-19, building a resilient health system in Korea. Professor Hwang, please.
Hello, everyone. It's great to be here. It's my pleasure and honor to participate in this book seminar. I'll just share my screen first. And you see the screen, okay? Okay, so I'll try to brief you on the experience of Korea during COVID time and try to explain how the COVID experience in Korea was related to our MERS experience, which was 5 years ago, 5 years before COVID. And the MERS experience allowed Korea to build resilient health system between the time of MERS and COVID. So just to give you an overview of Korean healthcare system, it is based on social health insurance system. We have population coverage achieved. However, most providers are private, so less than 10% of the hospitals and 15% of the beds are public. However, we do have a network of primary public health services providers managed and funded by the government. It is called public health centers. So we have approximately 1 per 200,000 people in Korea. For disease surveillance and response, we have collaboration among different levels of government and institutions. For instance, at the top, we have the Ministry of Health and Welfare that manages and oversees the health policy. And we have the KDCA, or Korea Disease Control Prevention Agency, similar to the CDC in US, that oversees the health policy regarding infectious diseases. And we have regional and local governments that are responsible for managing local, regional level public medical hospitals and relevant institutions and public services such as vaccination. And we also have a network of both private and public providers across the country, and laboratories that were quite useful to conduct testings during time of COVID. This just show you the flow of financing and service delivery between those key infectious disease control and prevention organizations. So COVID in Korea, experience of COVID in Korea was praised by many studies recently, and for being able to flatten the curve early in the stage and keeping it low. If you see the graph on the right bottom, the fatality rate of COVID-19 in Korea remained quite low compared to other countries. And I would like to argue that it is the result of being prepared and implementing early stage response that were enabled by previous infectious disease outbreak experience, namely MERS. So for instance, for preparedness, Korea at the time of COVID already had infectious disease surveillance system, public health network, and a framework act on the National Disaster Management System. And early response included heavy testing and tracing. If you see the table on your left bottom, it outlines key dates of COVID experience in Korea. So the first case of COVID-19 was reported in January 20th, 2020 in Korea. However, 11 days before the first case was reported, Korea actually had COVID-19 testing method, not the RT-PCR, but and corona testing method. So we already had a testing method for COVID-19 before first case arrived in Korea. I actually checked the dates again to make sure I'm not saying the wrong dates, but I would like to argue that this is the result of being prepared due to past infectious disease outbreak experience. Another key dates include emergency use authorization program starting in drive-through screening and so on. So back to 2015, Korea was actually one of the countries outside of the Middle East region that experienced very severe MERS. Out of nearly 200 people infected, we had 38 deaths, so fatality rate of 20%. And it was mainly spread through hospital infections, nosocomial infections, being the government failing to trace and test in early stage. So government at the time was heavily criticized for absence of preemptive measures and inadequate quarantine system, the capability of epidemiological investigation. And in the time following MERS, the government implemented nearly 50 reforms. All of them were implemented, some of them still being implemented. Key areas of the reform included increasing the responsibility and autonomy authority of the key public health agencies such as KDCA, investing in R&Ds, including diagnostic capabilities, and designing rapid response process for initial response, and creating active or real-time national stockpiling policy. Lastly, backing up these reforms by legislative background. So just to compare the experience of MERS and COVID-19 in Korea, for example, during time of MERS, contact tracing was done over the phone or over meetings or fax. However, at the time of COVID, thanks to our experience in MERS, we have already developed real-time IT-based contact tracing information system. The number of EIOs nearly quadrupled just in 5 years' time. So from now on, I'll try to introduce the experience of Korea during COVID-19 and connect that to each layer of resilient health system characteristics. For the first layer or risk reduction or preparedness, Korea had a network, still have network of public health providers, mainly public health centers that are similar to primary health hospitals. And sub-centers and health posts that are comparable to a doctor's office in rural areas. This network of public health service providers provide immunization, MCH services, and health education services such as smoking cessation or alcohol cessation services. These were heavily utilized and helpful during COVID-19 as vaccination sites or testing sites or reports of tracing came from these institutions. And we had financing sources, multiple financing sources that are complementary and sustained during COVID. First one is the health insurance, of course. And second is National Health Promotion Fund that is funded by the tobacco tax. And third is the Disaster Management Fund, which accumulates 1% of the regional or local government tax revenue set aside to be used during time of epidemics or pandemics. These funds were actually used during time of COVID to procure medical supplies needed in the region or provide relief fund to the general public. And there was already surveillance system in place. And regarding data and ICT systems, Korea, with its IT development, used the IT technology to develop real-time tracing systems and real-time epidemiological investigation systems that were used during time of COVID. So this picture just shows you the one of the public health centers in Seoul City, so 1 in 25. So it is about the size of a small hospital. So we had about this size of a small primary health service provider around the country. Currently, there are 260 of these in the country. So back to the first layer. Of course, these initiatives were not possible without the legal basis. So between MERS and COVID, the government actually implemented several legal reforms that increased government capacity for tracing and testing as well. And jump to the healthcare workforce, the government invested heavily to raise more workforce regarding epidemiological investigation. Second layer, for detection, as I said, Korea was possible to develop the testing kit even before COVID-19 was reported for the first time in Korea. This was possible, in my opinion, due to heavy investment by the government to commercial development of testing kits between MERS and COVID. And on top of that, the testing kit was able to be introduced to the market before proper authorization due to emergency use authorization program, which was established in 2016. And also these testing technologies were able to be used due to setting up test sites quickly across the nation, such as in hospitals or mainly on those public health centers around the country and or walk-in stations. Regarding contact tracing, IT technology was again heavily utilized to develop a real-time epidemiological investigation system, incorporating patient interviews, GPS data from cell phones, credit card information, CCTV, and records of health institution visits. This was also possible due to legislative reforms that allowed the government to collect data from multiple agencies. This is the example of the IT-based quarantine system, which was used during time of COVID. So basically, if I visited foreign countries and then came back to Korea and visited one of the hospitals in my neighborhood, they will know that I have visited a country that were at risk of COVID or other infectious diseases. I'm sorry. So regarding social measures, including isolation, also the amended IDCPA was in big help to ensure sustained supplies of medical supplies and enforcing the general public to wear the mask. And the risk communication was actually one of the area the government was heavily criticized during MERS. So after MERS, government created risk communication officer, dedicated risk communication officer, and a manual in the KDCA. And during COVID, there was daily briefing, actually twice daily briefing by the head of the KDCA on current status of COVID-19, such as the number of people confirmed infected or number of deaths and so on. And another second good example of second layer is the vaccination. If you see the graph, Korea is one of the heavily vaccinated country. I mean, it could be result of multiple reasons, but I do believe it is the result of procurement effort and good risk communication and cultural reasons as well. Lastly, we have the third layer, which I'm not going to spend too much time on. But Korea tried to redesign the patient referral system based on the patient severity to send the patient to tertiary hospitals if they are severe cases. So key takeaways, I believe, is that the government to prepare and to build good response to epidemics, the government leaders matters, and it is required to strengthen the existing community public health providers and institutions. And third, human resources are also matter, and we can utilize innovative technologies such as IT system or new diagnostic testing technologies can significantly benefit the countermeasures. Lastly, sustained financing and the legal foundation are critical to make those measures come true. And that is my presentation. Thank you very much.
Thank you, Dr. Hwang. So thank you for illustrating the three layers and how they're implemented in Korea. So next we'll have opening the floor for the question from the audience. Please kindly raise your hand later on and wait until you call the point. Share with us your name and then state your question afterwards. Our colleagues will go to you with the mic. So we would like to invite Dr. Phil Tinzek, lecturer School of Public Health, to facilitate the Q&A section. May I invite Dr. Tinzek to the stage, please? Thank you. May I also invite Dr. Zhao and Professor Bishai, please? Thank you.
So thank you so much, Rauja, and thank you so much, both authors of the book. So I would like to open the floor to actually raise your questions, and please ask any questions. Yes?
Thank you so much for your generous sharing. I'm a year one medical student. I really learned so much about the public health system. Just now, Professor Bishai, you mentioned how we don't need to wait to see returns in investment in this three-layer structure of public health. And we also saw like how Professor Hwang just now shared how Korea can see improvements from the MERS outbreak to the COVID outbreak. I wonder, for example, for any region, say Hong Kong, or how would we see improvements in this investment? Hopefully we don't need to wait until the next outbreak to see these returns. So how could this physically look like? Thank you.
Thank you for your question. What would happen if we were to improve our resilience now in the Hong Kong setting? we would go to the data that we have now about a few things. Cancer screening. We would look at the data showing how far behind we are at cancer screening. We would look at the data on who is not fulfilling their targets for mammography, for colonoscopy. We would look strategically on where the vaccine coverage is low. If we did our essential public health functions, that data analysis would be something that immediately turned into a stakeholder map, which we teach all of our MPH students how to do, and an action plan. You would immediately begin to address these low-hanging fruit in public health operations, and you would get those markers to move. Right now, because of many reasons, but one of them is we're not relying on the civil society and the NGO sector and the care teams that are outreach for us there. And we could activate them. We could activate them to help senior citizens who are sweltering during heat waves. We could go and reach them, but we have to be strategic about it. So we can begin to address things that are not a pandemic, but are still killing people unnecessarily in Hong Kong every year.
Yeah, if I can add one point. Actually, before this seminar, I had quite a few round-out conversation with the faculty members here and the student here. I had an interesting conversation with Hui Lin, our One Health expert. For example, Hong Kong is doing well in terms of data sharing between animal health department and the human health department. So this is Professor Bishai mentioned, there's a lot of pieces already in place. You don't have to reinvest. Just building on that collaboration will be great. For example, many countries are pushing for this integrated surveillance system, right? That's beyond data sharing, but you have the lab system, you have all the early warning system integrated between human health, environmental health, and animal health. That would be a good start. Climate change is critical agenda. We're not only talk about diseases, we talk about heat, which in Bangladesh we're doing a study on heat linking to health and mental health, which is a critical agenda. When we talk about health threat, we're talking about also climate change risks. Right?
Is there any more questions? Yes.
Thank you. I'm actually I'm a third-year PhD student. My question relates specifically to resilience as concerns PPR. And it's how do we guard against fatigue, right? So currently the pandemic is a big issue, and then the Korean experience. I think Korea was sort of, I'll say, lucky in the sense that MERS was just 5 years ago. But for a lot of countries, outbreaks cannot happen for another 10, 20, 30, 40, 50 years. So how do we prevent the system from getting rusty over this sort of, in the peacetime, how do you guard against that? Thank you.
So maybe, yes.
Great question. What we can learn from Korea is really the integration agenda. You integrate the public health function into the primary health care facility. You're not creating a new system, but you really use your existing system and strengthening it. The beauty of the three-layer system can help you systematically look into it. You look at the first layer, so it's the primary health care system, is the community-based approach. We can do a lot. Right? I was in Sri Lanka. One thing Sri Lanka did well is they have public health officers in uniforms, like police officer, integrated in primary health care. They're in the communities. It's amazing they have done that. So more we do that, the more better. The second layer, which Korea also have a lot to share, the key public health functions. In many countries, they still don't have CDC or public health institute. Zero. The investment in public health function in many countries, you will be astonished to see the amount of money they put in hospital, tertiary care, and the amount of money they put in public health institution and primary health care. It's such a contrast. So the more we do that, we have the key functions, as Professor Bishai mentioned, in place. We're much better prepared. Again, for the third layer, and that you need systematically think about the stockpile, vaccine capacity, and number of doctors. Many countries also have a lot of interactions. The hospital can be created quickly and can be folded away quickly. So it's not a permanent hospital. This is across different layers. There's many things we can do to increase resilience agenda.
Yes, is there any response from Professor Hong?
Just to add on Dr. Zhao's response, I believe long-term sustainable financing and legal foundation are quite important to carry out the plan of reforms over time. Because in Korea, the reforms were not carried out in 1 or 2 years, but over 4 years, and some reforms are still partially going on. So sustainable financing and legal foundation and government determination in carrying out those reforms continually, because the political vision actually changed between MERS and COVID, but the reforms have still been implemented. Thank you.
Thank you so much, Professor Wang. So I also would like to take the advantage of being the moderator. I have a very pressing question. So I think this framework, 3-tier framework, could be one of its kind after COVID-19. So when it comes to crisis, we have definition by the United Nations. So it is not only about disaster or pandemic, it is also about conflicts, violence. And there are 2 billion people living in conflicts and violence settings, but some of the frameworks are not applicable at all. So actually, we are constantly looking for very valuable frameworks to rebuild such kind of health system. So your insights will be really valuable for Colombia, for Myanmar, and many countries. Could you?
As I mentioned in the beginning in my talk, the hidden agenda is to make primary healthcare system more relevant, more adaptable, more comprehensive. Right now, our primary healthcare system in many countries is very narrow. It's not really relevant to the current situation. For example, in many countries, the PHC system is really relevant to maternal and child care, immunization, family planning, you name it. Nothing to do with NCD, mental health, conflict, women-centered, gender-focused approach. So the more we do that, similarly as we talk about pandemic, the more we're in a better place. So this framework, of course, the entry point is really on pandemic outbreak focused. It's not applicable to all the situations, but I agree with you. So we need to come up with a stronger primary healthcare system which we can adopt to different situations. Right now, there's conflict everywhere. We're in a world which is really we need to reconsider the health system. You know, you see the conflict in Middle East. We were talking about before this meeting. We talked about the Rohingya refugee, which I was in Bangladesh not long time ago. Do we have a system to really taking care of that? I don't think so. So we have to constantly evolve our system. So I have my bias. I feel the primary healthcare system, which will have a foundation, we need to invest more. A hospital is needed, is part of the system, but it's not the answer to low-income country, developing country, and to the rural settings. Yeah.
I'd like to answer as well. There are some ways in which building this primary layer can survive a civil war or a conflict, and the cases I have in mind are Sri Lanka. Sri Lanka was able to improve infant mortality and under 5 mortality despite a long-going civil war because it had an army of community health workers and NGOs. The Sarvodaya NGO wasn't non-governmental solution to primary health care, and it didn't matter whether you were on either side of the civil war. Families still got services. The same in Nepal. Nepal went through a prolonged civil war, but they had a tradition of volunteer community health workers. It's the cases where you rely on the top layer only, where you're all waiting for cure, for medicines and hospitals, where a conflict is devastating. Those things are, as we can see, very, very vulnerable to conflict, and the high-tech staff that staff these hospitals, they vanish during a conflict. But if you build your foundation on a community health worker foundation, you can actually make improvements in health despite conflict. Not that this is something where, oh, you're going to have a war, you better build primary health care, but honestly, it is something that will serve you well no matter what the crisis might look like.
Thank you so much, Professor Bishai, and thank you so much, Professor Tom. I think we are running out of the time, so I really would like to say thank you to all the people who asked questions. There is one pressing question. Yes.
Again, speak out loud. So my name is Dr. Feng Zhao. Most recently, I was based in Pakistan working on a project with CDC. I met you earlier this year in January in Pakistan at a conference. So when we talk about climate finance underway right now, COP is underway, and we talk about climate finance, we talk about climate resilient health systems. Not a lot of it goes on the ground. Like Pakistan is one of the most prone to disasters. We have these remote regions in the mountains where nothing goes on on the ground. Right now I'm working on a research project, a pilot study, where we're checking mental health and climate change. So these are the people who get scared even with a drop of rain because they're scared that they will lose their livelihoods, their houses again. You mentioned about health ministers and finance ministers with the least interaction. And it's the same thing with the climate change. So in terms of financing, how do you see these climate change ministers, health ministers and finance ministers collaborating and integrating together to build a climate resilient health system?
So part of that half a penny investment that isn't going to take much from the finance minister would be the centurion that asks their local health department, not are you solving climate change, but did you just happen to convene the Red Cross and the transport facilities and the care teams and the nursing homes, just convene them off of your budget to ask about what we're going to do in a heat wave and to build a heat health action plan. Here in Hong Kong, we think urban, but in Pakistan, you would ask for a community-based strategy to think about what to do in the heat wave to get people into cooling measures. These could be evaporative cooling measures. It doesn't have to be an air conditioner. But to ask the health department to do its job and to remember that heat is lethal every summer. So we're not asking for this major adaptive remark. And again, in public health, we think of adaptation as much more important for what we're good at. We're not good at measuring carbon and changing forms of energy. We're good at having communities gather together to solve their problems by getting data, finding out who's vulnerable, and having a plan for them. So this is not a large investment. We're asking for public health to do what it needs to do and realize that this is on the to-do list. Here in Hong Kong, you're sitting next to Roro Liu, whose work showed that last year, heat-related deaths edged out diabetes as our number 10 cause of death in Hong Kong. And yet our health department needs to get back to realize that that is part of the to-do list and talking about what can we do to lower that death rate during heat waves in Hong Kong.
So, a couple of general points. It's even more complex when you put three ministries together. But one thing I learned from talking to Minister of Finance is the worst thing you want to do is you ask more while your existing budget is not running efficiently, right? That's self-defeating. How do you improve efficiency is the big agenda for Minister of Finance. So the efficiency agenda need to come first. How do you use your existing budget to quantify the results? That has to be there. Otherwise, just keep asking more. That's not going to work because all sectors have pressing need. That's one. Second one is you need to have holistic priority. In the health sector, we often contradict ourselves. Is you have the HIV program, the director went to Minister of Finance. You have the malaria and TB and all different programs competing among ourselves. Unless you have a holistic priority, you have a plan moving forward collectively, it's not going to work. Climate is really a vivid example of it, right? So there's so many pressing need on mitigation side, on adaptation side. So the country's strategy is the place to convene all the views. Unless you buy in this one strategy, which means our finance also support, it will not gonna work.
Thank you, Professor Bishai, and thank you so much, Professor Zhao. So I think we are running out of time, so I would like to say thank you to our professor and also very fruitful Q&A session. Thank you so much.
Thank you for Dr. Inuk for the facilitation. I would like to invite Dr. Zhao and Professor Bishai remain at the stage for the good photo with your book. May I also invite Professor Kelvin Wang, Professor Herling Young, please come forward to the stage to take a good photo together. So